It's the podcast for the Parkinson's community. And we talk about all things Parkinson's, from research, treatment, exercise, of course, and real life stories and support for people with Parkinson's. I'm Maria.
And I'm Vicky, and today we are diving into something that's getting a lot more attention lately, the early signs of Parkinson's that can show up years before a diagnosis. It's called Prodromal Parkinson's, and it might surprise you how early the signs can appear.
Yeah, so to help us make sense of it all, we're joined by a leading expert in this field, Professor Alastair Noyce. Hello, welcome. Alastair, he's a Professor of Neurology and Neuroepidemiology at Queen Mary's University of London, a consultant neurologist at Barts Health NHS Trust, and he has a background in neuroscience, epidemiology, and years of clinical expertise. Alastair also heads up the Centre for Preventive Neurology, where his research focuses on identifying Parkinson's earlier and changing how we understand this condition.
Yeah, and we'll be asking Alastair, and thank you so much for joining us, what the early signs are, whether anything can be done during this phase, and what hope there is for an earlier diagnosis or early prevention. So, Maria, let's get into it.
Yeah, indeed. So, welcome. Thank you, Alastair, for joining us today. And so, just for those who might not be familiar, could you start by explaining what exactly is prodromal Parkinson's? What does it mean, and how does it differ really from like typical Parkinson's that the general public may know about?
Yeah, thank you for inviting me. First of all, it's really great to be talking on this subject with you both. So, most people get a diagnosis of Parkinson's when they notice changes in movement, things like tremor, slowing down, difficulty with fine motor tasks like handwriting, buttons, things like that, doing up buttons and things like that. And either they notice it or someone else notices it, and they are referred usually by their GP then to someone who specializes in Parkinson's, either a movement disorders neurologist, general neurologist, or a geriatrician. And when you see those clinicians, those doctors in the clinic, they're looking for signs of Parkinson's disease, motor signs of Parkinson's, and that's currently how we make the diagnosis and the point that we make the diagnosis. But actually, the changes in the brain, the changes in the body that we know are due to Parkinson's start much earlier than that. So by the time those typical motor symptoms are clear, are overt or apparent, actually the changes in the brain and the body have been there for quite a long time. And if you ask people in the clinic about what happened to them before they ended up coming to see you in the clinic, actually lots of people endorse other changes over time. Some of those are motor, subtle changes in movement over time, but some of them are things like loss of sense of smell, changes in sleep, and particularly a tendency for vivid dreams in which people then act out their dreams or talk in their sleep or shout out in their sleep. We call that dream enactment behavior. Low mood, anxiety, depression, things like that, and sometimes bladder or bowel complaints. And so all of these things represent what is known now as the kind of prodromal phase of Parkinson's. And some of these things may start 5, 10, or even 15 years before people get an eventual diagnosis based on the movement features.
What first drew you to study the early stages of Parkinson's before people are formally diagnosed?
Yes, so my interest in Parkinson's disease and the earliest signs is really has been for more than 20 years. When I was a fourth year medical student, I did a summer project looking at smell loss in people with Parkinson's and essential tremor. And I got really interested in sense of smell, and I got really interested in Parkinson's. And then when I finished medical school, I started this dual clinical academic training track. And the project that I dreamt up along with my supervisor at the time was around using smell loss and other tools to detect Parkinson's early. And all diseases, whether they're neurological diseases, rheumatological diseases, cancer, all diseases and research into disease is often focused on earlier detection and trying to prevent bad things from happening to people with those diseases. So, Parkinson's is no different. We recognize that we have good treatment for most of the symptoms of Parkinson's, but at the moment we have no cure. And we think that at least part of that, although there are lots of reasons why, but part of that is that we haven't done trials in people at an early enough stage. And so, a lot of the work in prodromal Parkinson's is about trying to identify people earlier so you can enroll them into trials and try and prevent progression to what we currently recognize as Parkinson's.
Yeah.
Okay. Yeah, fantastic. It makes complete sense. So you talked about smell loss and constipation, and so these sort of, I guess what they referred as like non-motor, like you said, these non-motor signs, these signs that seem to be apparent much earlier. But so how are they? Because the general public, I think generally that's what we hear is that they see tremor as the first sign, and if you ask most people, they'll say, "Oh, what is Parkinson's?" I think, "Oh, that condition where you shake a bit," and that tends to be what they understand. So how are these other signs like constipation, loss of smell? How is that related to what we actually know as Parkinson's?
Yeah, I mean, tremor at rest in particular is a pretty good indicator of Parkinson's, but only 2/3 of people with Parkinson's have a tremor. And actually, once Parkinson's has been diagnosed, up to 90% have smell loss. So smell loss is much more common than tremor in Parkinson's. Which is always,
I don't have a tremor, but I have smell loss. Yeah.
You have smell loss, yeah. So that's always been a kind of curious thing. I think the important thing to note is there are not many other things that cause tremor at rest, but there are lots of things that can cause smell loss. If we think about the COVID pandemic, everyone became aware of of smell loss and the like. So, but smell loss in a proportion of people as they get older, unexplained smell loss in a proportion of people as they get older, will be due to an underlying neurological process, either Parkinson's or Alzheimer's. This issue of dream enactment behavior, it's not that common in the general population, but if people do have it, then it is a pretty strong indicator that there's something going on, Parkinson's related. Constipation is more challenging. So constipation is really, really common as people get older, as they go through midlife, as they get into an older life. Most of the people that have constipation will not get Parkinson's. So that's a non-specific thing. But, there is some evidence, and including our research, that shows that in people that get a diagnosis of Parkinson's, they've had constipation for 20 years already. And so, this has kind of led to some ideas about Parkinson's starting in the gut and then maybe moving through the nervous system to the brain. And again, anxiety and depression, these are also pretty common as people get older, not necessarily due to Parkinson's. So of all the things, there's a whole myriad or constellation of possible things that can happen. But the things that I think are more specific for Parkinson's are unexplained smell loss, dream enactment behavior, and subtle motor change that progresses over time.
So do you think
it's interesting.
when you see those, that to you then, that's the hard thing, isn't it? As clinicians, is recognizing that these things are actually potentially prodromal. Is that prodromal Parkinson's? If people turned up with you with a lack of sense of smell, constipation, and dream enactment, would you say, okay, you have I can now say that you have a diagnosis of prodromal Parkinson's?
Yeah. I think we don't make a clinical diagnosis of prodromal Parkinson's. What I say to people, and I see quite a lot of people in clinic that have either REM sleep behavior disorder and dream enactment behavior, or with unexplained smell loss. What I say to them is, we'll keep an eye on this. For people with RBD, it is a strong, more strongly associated with Parkinson's than smell loss. So I would usually, see those people with an interval of, say, every 6 months, just to see if anything's changing. People with smell loss, I'm a bit more of a prolonged interval, you know, kind of every year or 18 months, just to see. And with the smell loss, it's also important to involve an ENT surgeon and just make sure that they have a look up the nose and that you've done a scan of the brain to make sure there's no other, you know, recognized cause for smell loss as one gets older. But I don't diagnose anyone with prodromal Parkinson's. I say, well, you know, there's no signs that you have Parkinson's or a similar condition at this point. But if you would like me to see you after an interval, then I'm very happy to do so, and we'll just keep the situation under review.
Yeah. Alastair, both my mother and grandmother had Parkinson's. Does someone's family history or genetics play a role in identifying risk during this early phase?
Yeah, absolutely. I mean, our understanding of the genetic basis of Parkinson's is pretty mature. It's likely in about 10% of people with Parkinson's, there is a kind of recognizable genetic cause. So mutations in certain genes that are inherited either in a dominant or recessive pattern, or that are strong genetic risk factors are present in about 10% of people. But it's likely that even in people without a strong family history, there is a genetic component, but it's usually just quite a dilute, watered down genetic component.
Yeah, that's interesting, isn't it? And now that sort of prodromal Parkinson's, I suppose, has been defined, are we getting close to having a reliable test or a marker that could spot Parkinson's before the obvious movement symptoms appear?
So there's a lot of work. One of the most exciting things right now is the kind of work in biomarkers for Parkinson's diagnosis. And I think, you know, we are pretty close to having diagnostic markers for Parkinson's. At the moment, those diagnostic markers perform best in spinal fluid analysis, and they exist really in a research setting only. There's some evidence to suggest that those markers work in skin biopsies, particularly skin biopsies from the back of the neck. And there's work ongoing, but it's much more challenging to develop those markers in blood. I do anticipate that those markers will support clinical diagnosis in people with the motor signs of Parkinson's in the coming years, in the not too distant future. And as it hopefully stops being a spinal fluid test and starts to move to, you know, skin biopsy or blood test, that becomes more accessible and more possible. But research also tells us that certain people with smell loss, people with REM sleep behavior disorder, this dream enactment behavior, they're also positive, for this marker. So about 90% of people with REM sleep behavior disorder are positive for this marker in research studies, and about 50% of people with unexplained smell loss as they get older are positive for this marker. So smell loss seems to be a good proxy for this positive marker. This marker is known as the alpha-synuclein seeding aggregation assay. So I think it's a very exciting time for diagnostic markers. You know, I think one of the things that often gets mentioned is whether we're close to a screening test for Parkinson's. I don't think we're close to a screening test for Parkinson's at all, because, you know, there are very few diseases in which we implement population-based screening. You know, a handful of cancers, there's only about 5 or 6 things that we do population-based screening for. But where I think these tests will come in is in early detection. So a bit like now, if you have an isolated tremor and you go to see a neurologist, they may do a DAT scan to decide whether that tremor is due to Parkinson's or not. I think what we may do in the not too distant future, in someone that has, you know, REM sleep behavior disorder or unexplained smell loss, we may do a synuclein test to see whether that's likely to be due to incipient Parkinson's.
And if, for instance, that did come back as a positive, have we got enough evidence to say then that that's a foregone conclusion that person will go on to develop motor signs of Parkinson's?
No, and I think that is a critical question right now. So what we know is that, again, based on the studies that have been done so far, that about 10 to 15% of older people are positive for this Parkinson's marker in their spinal fluid. And now what's not clear, because clearly most of that 10 to 15% don't subsequently get diagnosed with Parkinson's in their life. So it's not enough to be positive for the marker, but if you're positive for the marker and you have some early signs that we would, and symptoms that we would associate with Parkinson's, then I would certainly follow that person up and keep a close eye.
But I guess there's no, like everything with Parkinson's, everybody is so individual, aren't they?
Yeah.
So again, defining that timeline must be really difficult, and is going to be different for every single person, is it?
It will be, but I do think, in the Alzheimer's world, we now have moderately effective disease-modifying drugs for Alzheimer's. They're kind of modestly to moderately effective. They're by no means a cure for Alzheimer's disease, but we have those drugs available through certain routes in the UK, in the US, in Japan, and the like. And that the success of those trials has been because people were enrolled in those trials with early signs, and they were tested for a biomarker, positive for that biomarker, and that led the recruitment to the trial. I do believe that's what's going to happen in the Parkinson's field. People with early signs like REM sleep behavior disorder, like smell loss, who are then positive for the marker in their spinal fluid or in their skin biopsy, and maybe in their blood, will be enrolled into trials, and then we'll be able to really test those drugs. So as you say, Parkinson's is very heterogeneous disease, lots of different causes of Parkinson's, lots of different manifestations. But if we put people into trials, we invite people into trials that have a pretty robust early sign and the marker, then we're trying to make that pool of people more similar to one another, and then we know that we're testing a more homogeneous group of people with the drug of interest.
Yeah, so interesting, isn't it? So on the other side, you obviously we've got the drugs, but there's lots of technology out there as well. There's apps, there's wearable technology. Can that play a part in picking up signs of progression or early, other signs as well?
Yes, absolutely. I mean, so that I would say first of all that we do need technology even to pick up those early non-motor features like the smell loss and the REM sleep behavior disorder. It's certainly not enough to feel like you have lost your sense of smell. I would always recommend that people have their sense of smell tested objectively with a smell test. With REM sleep behavior disorder, I wouldn't trust necessarily that people endorse vivid action-packed dreams and movement in their sleep as being indicative of REM sleep behavior disorder. I would always recommend there's an overnight sleep study. So these are both technologies that make that diagnosis. And similarly for motor dysfunction, I believe that subtle motor dysfunction goes back quite a long time before someone gets a diagnosis. Yeah. And we and others have used tools to try and capture that emerging motor dysfunction over time. Just like the non-motor features, subtle motor dysfunction may go back 3, 5, even 10 years before. What's interesting and what I think is important about technology is you can use it to track changes over time. But I think the most sensitive tools are likely to be those where you stress the motor system in a way that makes it clear that it's not working properly. And the way to stress the motor system is to get someone to do a motor task, and then to get them to do a cognitive task while they're doing it. And
God, so I'd be hopeless.
So, but I use this in clinic in people with REM sleep behavior disorder as well. So I'll ask someone to walk up and down, absolutely fine, but then I'll get them to do some mental calculations out loud whilst they're walking, and you see the breakdown in the walking, the arm swing starts to go, and the cadence of the walk starts to go. So I believe that the most sensitive tools for early detection will be those that stress either the cognitive system or the motor system.
Does that explain like my grades weren't so good at school?
Well, I'm not sure we can.
No, I'm kidding. No, okay, they weren't that bad actually. I'm putting myself down. What I found really interesting And this is on the sort of more early onset. So I'd say this is people that I've met over the course of the last 4 years. So no way, I have no way as much experience as the two of you. But those sort of in their 40s, 50s, all of them, well, not all of them, but I'd say a really high proportion have had a really stressful event, not just everyday stress, but a really stressful event happen prior to their diagnosis. And that for me, I have found fascinating because that was the case for me. Can you explain why that might be the case with Parkinson's? I mean, is it just one of those things for all diseases? We know that stress is not good for our bodies.
I think first of all, that's true. I think that stress is an enormous cause of morbidity in the population, whether it's obesity, whether it's skin diseases, rheumatological diseases, or neurological diseases. I think stress has a massive impact on our immune systems and our ability to regulate our bodily processes. I've quite a lot of thoughts on the role of stress. I'll give you a couple of examples. So in short, I believe that stress is important, is an important factor in Parkinson's initiation. I believe we will be able to demonstrate that in time, but it's quite hard to demonstrate.
Yeah.
We say that most people with Parkinson's, we don't really know why they got Parkinson's. We say, it's a complex disease. There's partly genetic, it's partly environmental, but in most people we don't have the cause. It's quite likely that in the majority of people with Parkinson's, there was an initiating event that is hard to put one's finger on, and that then environmental exposures and genetic factors are the things that cause that initiating event to continue from that point. And so I think stress is an important thing. I also think with the passage of time, we'll find out that certain systemic infections were important, and infections also have a stressful effect on the bodily processes. So I believe these things will all turn out to be very important. And I agree with you. In my practice, I see hundreds of people with Parkinson's, and it is pretty striking how many talk about a recent life event or very stressful work that ultimately led to them stopping working, and then suddenly they notice the signs of Parkinson's.
I find it so extraordinary.
We have lots of the people that exercise with us, they tend to come from that environment where they've worked in high-powered jobs as well before. They're all still are. We work with a lot of people with young onset that are still in this stressful environment and working, and definitely we see that a lot.
Yeah.
Are there clinical trials happening now in the prodromal stage?
Yes, but not many. I mean, just again, like the Alzheimer's field, the focus right now is on the what we call the clinical phase of Parkinson's, the phase after people get a clinical diagnosis of Parkinson's, and also that's right. Okay, really investigating the prodrome is a focus of research, but there are tens of thousands of people in the UK, millions in the world that have Parkinson's disease. So it's right that the focus of research is on clinical trials for those people. But there are trials starting for prodromal. There are anti-inflammatory trials starting in the US for people with REM sleep behavior disorders. Very, very interesting study called PRISMS that's starting. We are part of a group called Slow Speed that's being run from the Netherlands and in the US and in the UK. We're the main UK site where we will be enrolling people with hyposmia, unexplained smell loss, into an exercise intervention program for an 18-month just feasibility study starting later this year. In the Netherlands, they're recruiting people with REM sleep behavior disorder, and in the US, they'll be recruiting people with Parkinson's genes into an exercise program. So there are things starting, and we'll be looking to enroll people with smell loss into Slow Speed later this year.
I'm really interested because we know also the SPARK study, which is a study that's going on in the US and Canada.
Exactly,
their phase 3 of that, and so we're hoping to understand a bit more about the prescription for Parkinson's and getting the right dose, because we need to understand a little bit more about that, as you know. And obviously they're looking at people with early diagnosis of Parkinson's, aren't they, that are not yet on any medication for that study.
Exactly. Yeah. So, and there's another study in the Netherlands called Stepwise, which is focused on exercise in people with a diagnosis of Parkinson's. But this slow speed initiative, which is led by Bas Bloem and Sirwan Darwish in the Netherlands and by us in the UK, is really trying to see whether people who are hypothetically at risk of Parkinson's will engage in an exercise program long term to reduce their risk of future Parkinson's.
Yeah, that's absolutely brilliant, isn't it? Amazing. So for those watching and for those sort of out there that might consider themselves, I suppose, in the prodromal stage, might have the constipation or smell loss, what would you recommend? Go and get that checked out?
Yeah, I think that's fine. I mean, I think if you are worried that you've lost your sense of smell, you can see your primary care doctor, your GP, and ask them what they think, and they may refer you on to a dedicated smell and taste clinic or to a neurology clinic for further investigation. If you and particularly a kind of partner recognize dream enactment behavior, again, first protocol would be to see the GP and be referred on for an overnight sleep study for a diagnosis. For smell loss, it's important that it's investigated. What's the underlying cause? For REM sleep behavior disorder, dream enactment behavior can be vigorous. You can hurt your partner, you can fall out of bed, you can injure yourself. So that really does need a formal diagnosis and proper treatment. And certainly, those people I will follow up in my clinic. I'm sure others do as well. So yeah, and obviously if you have kind of motor dysfunction, subtle tremor, difficulty with fine motor movements, changes in handwriting, that should also prompt referral.
And I think it's recognizing those very subtle things, and then now for the general public, just understanding that on top of that, if they have loss of sense of smell and all the other things we've spoken about today, then really it's educating people to recognize that, isn't it?
Yeah, and knowing that there isn't an inevitability about this. So if for anyone listening, if your sense of smell is not as good as it once was, and you feel like you might act out your dreams, still more likely than not you won't get Parkinson's disease. But it's perfectly reasonable to be referred, be checked, have someone examine you and say, look, I think everything's fine here. Happy to see you again in a year and check that everything's still fine. And if things are still fine, we'll discharge you at that point. And if anything changes, come back again. So
brilliant.
And I suppose for caregivers and family members supporting them, it's important for them to get educated as well and be able to, help them know that it's not all doom and gloom. And is that what you suggest? Yeah,
absolutely. Yeah. I mean, I think there's I think one of the benefits of raising awareness about the early stages of things like Parkinson's is you're raising awareness about brain health in general. And so, even if ultimately at that point in time, there's nothing to find, nothing that's concerning, hopefully there's an opportunity to engage that individual or that pair of individuals in adopting approaches that maintain their brain health long term. Because it's not just Parkinson's that people get as they get older, and actually even in people with a diagnosis of Parkinson's, there's probably a degree of vascular disease, there's probably a degree of other brain changes going on. And so adopting a brain healthy lifestyle from as early as possible is a good thing.
So do Wordle every day, or play table tennis and do the times table at the same time?
Absolutely.
Just some suggestions. Sorry, Maria.
No, I was going to ask. So when you do see these people in clinic, does it give you an opportunity to talk about exercise and diet? And
absolutely. And I think, I'm a culprit for this, but also the way, just the way we do exercise in midlife is also not is not terribly good. You know, we sit at a desk for 8 or 10 hours a day, then we run around outside for half an hour and, you know, get our heart rate up, but that's not particularly good for our spines or anything. And, you know, we think that, oh, well, I've done some exercise today. So really kind of, I mean, you're the expert on this, but really kind of, you know, varied exercise, some exercise that's aerobic, some exercise that's resistance work to build core strength, some that's around stretching and you know, improving flexibility. Really important. Social interaction, really important. I mean, what an impact COVID had on the whole world, but social interaction is really important. Healthy, balanced diet from the earliest, you know, point in life that you can, not drinking too much, not smoking, avoiding things like diabetes, high blood pressure, avoiding stress or managing stress effectively. These are all so important.
I'm saying my husband has this saying now, because I'm guessing we're all of a similar age here, that we're all in Sniper's Alley.
Sniper Valley.
Sniper's Alley.
Sniper's Alley, yeah.
It's only a matter of time. So, you know, it's so important for everybody out there to exercise, to engage in, you know, to think about what we're doing and all of those things in so many conditions, chronic conditions.
Yeah, it's never too early and it's never too late as well. So,
and actually, one of the things I focus on that I find is the best is the mixture of strength and cardio, you know, to try and do a bit of that to raise the heart rate. We know is really important in Parkinson's, but also the strength to protect that skeleton, to protect your bones. But we always say, you know, do what you enjoy. But
Exactly. I tell people that. I say, do the exercise that you will enjoy doing, that you will engage with regularly, but ideally it should encompass all of these things. It's amazing, since, I mean, the work that you both are doing is so important for the Parkinson's community. But it's really interesting that since I started to push a real kind of exercise narrative in the consultation, and people take it on, they are doing really well. Doing really well.
It is very, very heartwarming, actually, to see people almost, I'd say a lot of people are like, thank you, Parkinson's, because they've actually changed their lives for the better. They've introduced a more healthier lifestyle. They're exercising and doing things they wouldn't have done before. I'm not saying we all want it, but you're absolutely right. It is really encouraging to see people, how they're getting on.
And something else that we often say to people who are exercising as well with us is that, you know, that picture of that, there's a
Wikipedia.
There is a textbook that I qualified at quite a long time ago, and certainly when I learned about Parkinson's at university, it was from this picture of somebody, old person, shuffling.
I know the picture.
Gait,
we all know the picture.
And we just kind of say, well, do you know what? That's not you, because actually you don't know what you're going to look like. Because actually we've never exercised people as hard as we are exercising people with Parkinson's now. So actually we don't know what you're potentially going to look like in the future. So
it needs to be. I need to contact Wikipedia
and get it taken down,
because it's so awful, isn't it? Here.
Yeah, I know the guy.
I mean, it's like, what?
Yeah, that's not you, Vicky. That's definitely not you.
No, not unless I dress up.
But it's exciting times, and for me as a physiotherapist, it's so great being able to empower people to actually take control. I think that's the beauty of working and exercising people, being able to offer them the tools to be able to do something. And that's what people tell us. It's just like, just now I know what I can do. Is there, they're always like, is there anything I can do to help me? And it's
absolutely
to do that.
Absolutely. I mean, I think we are going to be doing more and more in the way of intervention studies. This is where I always, 20 years ago when I started to get interested in this is where I wanted to get to, not just watching what happens to people over time, but actually trying to do something. So if people listening do want to get involved in research, we have a study that they can join called Predict PD, which is, the website is predictpd.com. You can sign up, register, fill in some surveys, and we'll send out smell tests and genetic tests and things like that. So people are very welcome to join.
brilliant.
brilliant.
Thanks, Alastair. Thank you so much. And just to round it all off, if there is one message, one key message you would like to give to this community about early stage Parkinson's, or what they should be doing, what is it? What's your key message?
Pressure.
Yeah, pressure. I mean, I think you know, for the people with Parkinson's listening, I would say that I think this is a really kind of exciting time in the field, where we're getting close to diagnostic markers. And you know, in other fields of medicine, once you have diagnostic markers that are not based on this, the trials that follow tend to show signals. So I think it's a really exciting time for kind of drug development and therapeutic development for Parkinson's disease. Whether you have Parkinson's, or you may have an early phase of Parkinson's, what I would endorse is you know, adopting a brain healthy lifestyle, never too early and never too late. And we talked about the various things that are involved in that. And if you are concerned about symptoms that you have, I think it's perfectly reasonable to consult your primary care doctor and be referred to see a neurologist. There's a lot of pressure on neurology services in the United Kingdom right now, but these are legitimate reasons to consult and be seen, and you know, well, I'd be happy to see you. So I'm sure others would be too.
Yeah. Thank you so much.
Yeah.
So helpful. And yeah, I hope everyone out there enjoyed this. If you've got any questions, let us know, and do click on the link to subscribe so you can hear more of these episodes with Reach Your Peak. Thank you so much.
Thank you for having me.
No,
all right,
thank
brilliant.
you, Alastair. And just before we go, to
Yes.
our community, just to say, I've managed to get round to putting us on Spotify as well now.
Oh yes,
That's brilliant.
Yay.
Congratulations.
Yeah. Thank you very much. Really technology. So yeah, you can also find us on Shaking It Up podcast on Spotify as well. So if you want to listen again, that's where you'll find us.
Brilliant. Thank you so
Thanks,
much.
Maria.
Take care.
Thanks,
Bye.
Vicky.
Meet you.
Bye.
All the best.
Bye.
Bye bye.
Bye bye.